So we are going to talk about neurodevelopmental considerations, particularly when it comes to differential diagnosis and psychosis spectrum disorders. We're going to talk a lot about kind of the developmental spectrum and focusing very much on early development and our younger clients. I'll make sure I do touch on how some of these neurodevelopmental considerations may appear in adulthood because they look slightly different. We'll talk about differential diagnosis. We're not going to talk as much about treatment since this is about differential diagnosis, but I will have just a little bit on some treatment considerations towards the end. So that's me. I'm here. Hello. I have my PhD from UC San Diego, and I have a significant background in psychosis spectrum issues, as most of us do. But I am a clinically trained neuropsychologist, a pediatric neuropsychologist. So most of my early training was in neuropsychological assessment, particularly for our kiddos, and have done a lot of autism evals and autism rotations in my past. So really teasing apart these two difficult presenting symptoms, especially in our kiddos, is hard. So I am going to do my very, very best to give you some tips and pointers on that. So this is a bit about EPI-CAL and our training and technical assistance arm. So we are going to move past the slide, but thank you so much to our UC Davis, UC San Francisco, and Stanford University collaborating partners. And our goal really here is to make sure that we can standardize EP care across the state. And to do that, we have to have a good understanding of a lot of these comorbidities that comes up. So that's where I am coming in today. And resources for trainings are available at the link. If you have any questions ever on trainings, please contact Jessica, who is on this call right now. This is her email, or you can message her in the chat. All right, so today the point of our general presentation is to understand what neurodevelopment looks like, what typical development looks like, and where those deviations occur, and then what early onset psychosis looks like and how we can tease that apart from some things that are typically occurring in development versus those that are not typically occurring in development and maybe better seated in a different camp, even though they might look like psychosis, and then what it looks like when neurodevelopmental issues and psychosis are both present, and then some tips discerning symptoms. All righty. So developmental and lifespan considerations are significantly important for psychosis diagnosis. And part of that is because most of what we're doing is using a whole lot of theory of mind to say, please tell me what's going on in your head so I can tell you whether or not this is psychosis or something else. And that requires the person to be able to have that internal thinking, understand their thoughts, understand if they may be different than they were before, maybe different than what others have. And that particular cognitive skill, theory of mind, is A, one that doesn't develop until later, but B, is also one that is typically diminished in individuals who have a lot of neurodevelopmental considerations. Additionally, whenever we're thinking about developmental considerations or anything in general, we should be thinking about the whole human. So what environmental issues may be at play here? Stress and trauma, familial concerns, social issues, socioeconomic issues, really wanting to make sure that when you're saying, hey, this thing is this thing, that you ruled out other stuff. Particularly some environmental contexts that could be driving a lot of these behaviors. So let's start with just defining what neurodevelopmental disorders are. They are a particular group of disorders that start in early childhood and are marked by developmental deficits or delays, and produce significant impairments in social, academic, occupational, or personal functioning. The range of deficits is wide and vast, and some of them are very, very specific limitations to certain skills. Others are more global or impact social skills or executive functionings, intelligence, etc. And so we're going to go through three major neurodevelopmental disorders that particularly impact psychosis presentation, as well as we see them a bit more in our comorbidities. So we're going to start with intellectual development disorder. This was formerly known as mental retardation in DSM 3 and 4, and has been changed to ID in DSM 5. Intellectual development disorder is characterized by diminished capacity in one's cognitive abilities. So that's your problem solving and reasoning, planning, abstract thinking, memory, short-term memory, processing speed, etc. And this must be determined either by standardized tests. Most of the ones that we see are the Wechsler scales or the Kaufman battery. Or if we can't do a standardized testing, then we're able to confirm in another way. These deficits result in significant functioning deficits as well, particularly one's ability to care for oneself in daily life, their ability to communicate, having personal independence, social participation, and academic and occupational functioning. Global developmental delay is a diagnosis that we give to kiddos who tend to be somewhere between the 0 to 2 range, where we're seeing kind of this lag in their overall development. And so it's where we're seeing milestones not being met. Maybe their reflexes are a little slow to diminish in their 0 to 6 month range. Development of articulation, saying words, is slower. Motor development, maybe they're not walking as quickly, difficulty with gait and balance, things like that. And so we, again, usually do this systematic assessment. Again, the Wechsler scales go down fairly low, but they don't go all the way down to 0. So for our kiddos who are in that earlier age range, just a lot of just kind of testing of their reflexes, watching them do things and noting that it is delayed, diminished, or at a deficit. All right, and so I'm going to go back to intellectual disability. So this is a specific diagnosis in the DSM that requires someone to have had testing to be able to indicate that they are below a certain range. So individuals who are below an 85 IQ are what we call borderline intellectual developmental disorder. And individuals at 70 and below are individuals who have intellectual developmental disorder. That's why you see in our cutoffs, a lot of our cutoffs are an IQ of 70 and below, because that is the official cutoff in the DSM for having intellectual disability. So communication disorders are language-based disorders, particularly when it comes to speech fluency, their pragmatic use of speech, and their overall ability to communicate. Most kiddos have significant difficulty with fluency and pragmatic use of language in that 0 to 4 range. That's where they might mess up pronouns, or it seems like they can't really get those words out because their little mouths are still, kind of growing those muscles and trying to get those things out. So we tend to diagnose this once they are around 5 or 6, where their articulation should be at a certain point. All of those muscles have developed, and they're still having difficulty either with the actual production of speech or with its practical and contextual use. Can begin fairly early in life and may produce lifelong functional impairment. So when we think of like childhood onset fluency disorder, what we previously called stuttering, we think of like the King's speech and things like that. That's where speech therapists come in, etc. We'll talk about some of that pragmatic social communication issue when we get to autism spectrum disorders, because that's where a lot of those examples come from. Motor disorders are ones we see where someone may have specific motor developmental delays, stereotypic motor movement disorder, or tic disorders. That's where what we've previously called Tourette's often comes in. Kiddos below the age of 8 or 9 fairly commonly display some tics. Sometimes it's blinking their eyes, sometimes it's like tapping. You'll notice these like little motoric idiosyncrasies that should diminish over time. The difference is that, ones that are kind of just there and not really bugging anyone are fine. if it becomes impairing or a problem, that's where we actually have a diagnosis for motor disorders. Developmental coordination disorder is characterized by deficits in gross and fine motor skills. Particularly if we're seeing gait imbalance as they're running, you might see what seems like an ungainly or inefficient method of running or walking. Stereotypic movement disorder is diagnosed when individuals have repetitive and seemingly, driven and purposeless motor behaviors, flapping, body rocking, head banging, biting, hitting, things like that. We're not talking about excoriation disorders here, so skin picking. That still lives in trichotillomania. That does not live in the motor disorder camp. Tic disorders are, again, vocal tics usually. Often it can be blinking of eyes, or sometimes it's like, I can't really, like, it's almost like a jerky head movement I've seen before. And so it looks odd, as if someone's, like maybe trying to shake something off, but it becomes repetitive and it looks the same each time. So we're going over these disorders because what we know from the literature is about 50 to 60% of individuals who have psychosis spectrum disorders in their history have either a diagnosis or a suspected motor disorder, communication disorder, or some possible global developmental delay. So we often see these delays, balance issues, motor issues, cognitive issues well before any psychosis symptoms present. We also see specific learning disorders. So this is when someone has a particular disorder, not globally in their cognitive functioning, but in a particular academic skill. Acalculia or dyscalculia, difficulty with mathematic equations, mathematic representations. Dyslexia is difficulty with reading, writing, things like that. So we do see this a little bit less, but we do see this in individuals with psychosis. We've been doing this for a while. Most of us. How many of your kiddos are coming in with IEPs? How many of them are coming in with, they're all right in school, but even if they don't have full IEP. So we see a lot of these issues bubbling up. And whenever you see these, it's not like, oh, hey, this may be psychosis. It's more that it should be like a feather in your cap almost, to remind yourself, how am I putting this entire picture together? What's the parsimonious picture here of this young person? I'm seeing some of these little things here, there, everywhere. What does that mean for this individual? Where is this going for them? Because really, that's what we're interested in. How can we intervene to make sure wherever it might be going is a good place? Get to our major one, which is autism spectrum disorder. So autism spectrum disorders is a very complex neurodevelopmental disorder characterized by abnormalities in social behaviors, language and communication skills, as well as unusual behaviors or stereotyped interests. When we talk about communication issues and stereotype patterns of behavior, you're going to see a lot of the same motoric disorder type symptoms and communication symptoms. However, it's better characterized by autism spectrum disorders because it's not a standalone. So when you have the presence of one of two or more of these, that's when you're saying, okay, this is not an isolated motor developmental disorder. This is motor and communication that's better conceptualized as an autism spectrum disorder, not two separate diagnoses. This is just kind of a description of autism and its history. So Kanner is the first one who really coined that term, early infantile autism, to describe young children with autistic symptoms. But by and large, what we understand of autism spectrum disorders really started to come around in the 1930s or so. Just an interesting time because that's a bigger boom in the DSM in general. In our characterization of mental disorders and psychiatric conditions, but it's also a time where psychosis research really started to take off. So autism was thought to be biologically based, lifelong neurodevelopmental disability that's present right there in the first few years of life. But now we know that not necessarily is it fully biologically based. We know that it is, biologically We have that diathesis stress model, but we don't know any specific genes or areas of the brain associated with autism. Um, more or not more than psychosis, but definitively like, yes, this one is autism, or yes, this one is psychosis. We don't have those answers. So I'm not even going to present that research because why? But what we do know is there is clearly some sort of biological basis for risk, as well as some biological basis for how severe the autism symptoms are. So this is the DSM criteria for ASD: persistent deficits in social communication across multiple contexts, restricted repetitive behaviors, or social communication impairments. You can specify whether or not it is with accompanying intellectual impairment. So previously, you had to have some sort of intellectual impairment for an autism diagnosis. If you didn't, you had an Asperger's diagnosis. Now it's all subsumed under autism spectrum disorders, and then you specify with or without intellectual disability. Or without accompanying language impairment associated with known medical or genetic condition. So a lot of our kiddos that I've done evals on may have, Klinefelter's or DeGeorge syndrome. A lot of these, like 13q11, a lot of these genetic disorders that often accompany or often come with developmental delays, social communication issues, motor disturbances, etc. So they get the autism diagnosis as well, associated with another neurodevelopmental, mental, or behavioral disorder, or with catatonia. Autism across the spectrum. So as we have already said, autism has three major kind of categories of symptoms to it. Furthermore, it also has kind of a range within each of those categories, and you've got the range of intellectual disability, how much their functioning might be impacted, et cetera. So the major factors that kind of contribute to the spectrum we see are that they differ in that intellectual ability, language, the severity of language issues, and they are so heterogeneous in their presentation. I don't specialize in autism, but have done subspecialty rotations, and I got to tell you, like, I can't say, just like psychosis, any of them look exactly the same. So you have this spectrum of symptoms, and they kind of like overlap with some other ones, and it makes diagnosis particularly difficult. And that's kind of where we come in to talk about these things. How can we disentangle this? Well, what we do know are there is a debate about the core deficits. Is it like it's got to be language, got to be social, got to be stereotyped interests? There's different camps, but what we know is it should be kind of this conglomerate almost of these different issues that are all in all making this picture of this global issue with engaging in pragmatic everyday life, whether that's because of your communication, because of social cognition and awkwardness, because of some stereotyped interests. It's this general difficulty with navigating life as a neuroatypical individual. Let's talk about some of these social impairments. And as I'm talking about them, I know you're going to see a lot of stuff that could look like psychosis in here too. And I'll talk a little bit about that. So deficits in social and emotional reciprocity. So again, automatically we're thinking of some of these negative symptoms, right? Unusual nonverbal behaviors. So some of that is that difficulty with, keeping your gaze on somebody, or staring too intently. Most people, when they're looking at someone, they look for a few seconds, eyes flit to something else, they look back. A concentrated stare, though, usually kind of unsettles you. You're like, why are you staring at me like that? But that's some of those nonverbal behaviors that we'll see that just show a lack of social understanding. Social imitation. as opposed to social engagement. So I can mimic what you're doing socially. I can't necessarily understand what my part should be. And so it's not necessarily echolalic, but it could be like, how are you doing today? How are you doing today? They know to repeat it, but they don't know that they actually should have answered the question and say, yo, I'm good. So that's some of the things we see. Difficulty with sharing the focus of attention, as well as difficulty with make-believe play. Limited social expressiveness. So again, we're thinking psychosis, right? Blunting and flattening of affect. How do we tell that difference? Atypical processing of faces and facial expressions, also a social cognitive issue in psychosis. So I'm looking at someone and I think that they're mad at me. They're neutral. Their whole face is not doing anything, but you think that there may be some issue. And a difficulty with joint attention. Communication impairments. So one of the first signs of language impairments is inconsistent use of early pre-verbal communications. So we're talking about their ability to share communication even before they learn words. So proto-imperative gestures, pointing to an object you want, like, hey, give me that cup. Mom, I want some food, stuff like that. We're used to with toddlers, babies, because that's what they do. Hey, food, give it to me. However, proto-declative gestures are ones it's like you're trying to share in something. Oh my God, look at that plane. Mom, look, a cow. And those gestures are particularly diminished in individuals with autism spectrum disorders. They also miss declarative gestures. So when you try to show them or, hey, come over here, the use of your hands, as you can see, I talk with my hands a lot. So the use of your hands when you're talking to show someone else something, to give them the picture, those gestures are diminished even at an early age before they formed words, when they actually need to be using those gestures to communicate with their parents and the world around them. About 50% of individuals don't develop meaningful or useful communication at all. And so that's how severe those deficits in language can be. So instrumental and expressive gestures like, hey, stop, or give it to me, are expressive gestures. Instrumental gestures are sadness and embarrassment, and even those are diminished in autism spectrum disorders. So it's not that they won't necessarily do them, but they may not do them consistently. So when a baby wants to take something, they pick it up and they take it, right? It's kind of clear that they want that thing that you have. Give it to me. But even that, they may not take it. They may snatch it and throw it, and now nobody has it, or something of that nature. So even those kind of declarative, expressive gestures are diminished in individuals with autism. Those who begin to speak may regress. So the two gold standards that we use to diagnose autism are the Autism Diagnostic Observation Schedule. So that is the ADOS. Most people have heard of the ADOS. It's got four modules to it. Maybe 5. Sorry, it's been a while since I had to give the ADOS, but or give the upper modules of the ADOS, but the modules are different based on age. Modules 1 and 2 for our younger kiddos. 3 is where we start to get into that middle school. 4 is definitely for our young, for adolescents and young adults. And so, but we also give the autism diagnostic interview, and that's an interview with just the caregivers. And that's where we say, how were they with sharing? How were they with playing with other? What about imitating play, mimicking play? Like, Mom, I'm going to work just like you, or things like that. And one of those questions is, did they ever lose their communication abilities? Did they ever seem to have developed 2 to 3 word sentences, doing okay, and then all of a sudden, boom, gone? Why? So that's one of the things we ask about, that regression or that loss in communication abilities. Individuals who have autism spectrum disorders, if they are not part of that 50% who does not develop language, they do so usually by the age of 5, and then they have qualitative language impairment. So again, pronoun reversal, difficulty with I and you. So most people think it would be like others, but it's like, you went to the bathrooms. No, baby, you went to the bathroom. So you should say, I went to the bathroom. It's things like that. Echolalia, again, sometimes it's not like echolalic in their own speech. So echolalia means echoing, saying the same thing again. And sometimes it is, again, not knowing that you should not repeat somebody, but instead answer the question when it comes to like, how are you or good day. And then impairments in that pragmatic speech. So a good example of this is, can you look at me? Yes. They're not being smart. And as a Black mama, sometimes I'd be like, who are you talking to? But that's not what they mean. They're literally answering the question concretely. So there's a lot of times where we'll say, how concrete are they when we're asking about psychosis and trying to do differentials? Because when you ask a question, let's take the SIPs. Do you ever hear things that other people don't hear? Yes. Well, when I'm in a room by myself and no one else is there, of course I'm the only one that hears the TV. Like that's literally how they're going to answer the question. And they're not trying to be smart. They are answering it as they understood it in that very concrete way without the broader kind of pragmatic context. Okay. So this is our restricted and repetitive behaviors and interests. So if we're thinking about the full SIPs, I want you to go into the N and D symptoms. We've got some of those questions here: stereotyped body movements, repetitive sensory and motor behaviors, insistence on sameness behaviors, or self-stimulatory behaviors. And so there are different theories as to what the purpose is, what the etiology of these behaviors are. Sometimes, one theory is it's because they're craving stimulation and they need it in this specific form. Others, and I'm in this camp, think it's a way of blocking out overstimulation. And it's maintained by that sensory reinforcement. If you do it and it works, of course, you're going to keep doing it. So think of hand flapping, body rocking, going back to that motor disorders issue. That's where we're seeing these repetitive behaviors, particularly ones that are socially atypical or could even be harmful, especially if it's like head banging. You're banging your head on something, you might hurt it. So, when we see that, we're like, okay, that's one of the things I'm going to be thinking of that's in my autism folder. Also see some sensory issues, oversensitivities or undersensitivities to certain stimuli. So again, going back to the SIPs, we're thinking P4. Do you seem more sensitive to sound or light than you used to? The key there is than you used to. Someone who has an autism spectrum disorder is always going to have been sensitive to certain stimuli. Not recently. Yeah, the lights seem brighter now. That's new. So that's kind of that differential there, teasing that apart. Is this long-standing or is this new? Over selective and impaired shifting of attention to certain sensory input. So again, that need for, I want only this source of sensory input or sensory stimuli. Impairments in mixing across sensory modalities. So there are often times where they don't like different sensory inputs from different places. I want my noise canceling headphones on and maybe I can watch something. You can't touch me though. Like they have to have kind of a deadening almost of other sensory input. There tends to be sensory dominance. So one particular sense seems to either be the one for overstimulation or the one for overselective sensory input. And again, stimulus overselectivity can also be there. So about 70% of children with autism have co-occurring intellectual impairments. A common pattern is to have low verbal scores and higher nonverbal scores. That's something we almost consistently see. Oftentimes we'll give the with intellectual impairment diagnosis or specifier with autism, even if their global IQ couldn't be interpreted. So for some of our psychologists and those who just have been working with Wechsler tests and things like that for a while, that sometimes we can't always interpret the IQ because there's too big of a split between their verbal and their performance IQ. And so if either of them are significantly diminished, but particularly their verbal communication scores, their VCI, if that is below a 70, then that's when we'll say it's still with intellectual impairment. About 25% have splinter skills or islets of ability. So they'll sometimes we'll see that they've done not great on block design or a lot of the perceptual reasoning stuff, but visual puzzles or matrix will be out of this world. And you'll be like, where did that one, super high score come from? So they'll have these, what we call splinter skills or islet abilities. And then about 5% of them will have isolated or remarkable talents. If they're cognitive and motivational deficits, again, a single cognitive abnormality cannot explain all the deficits present in children with ASD. We can't say, oh, it's their verbal, it's their VCI. Nope, perceptual reasoning is an issue. We know social cognition is diminished, and those things do not live in the same places in the brain. Your social cognition is a loop in between your limbic system and your prefrontal cortex. You throw in some parietal lobe stuff as well. There are too many places in the brain active in these issues to be able to say this is some sort of like one-seated thing that we can see this trickle-down effect in. There is a view that individuals with autism have an underlying impairment in just social motivation in general. So I don't care about social issues. That is something that we tend to differentiate with autism. So instead of saying, oh, they just have social cognition deficits and that makes it hard, one of the differentials that we do is, are they actually interested in social interactions that aren't interest-based? So by that, I mean, it's not just that he and Alex really both enjoy trains. He actually cares about Alex. And if something happened to Alex, he would be sad. So that actual kind of social reciprocity, social engagement, those relationships, that's one of the things we see diminished in individuals with autism, the social motivation to interact with other human beings. So this prevalence data is somewhat outdated because the CDC just came out with some new stuff that I learned this morning. So I have not updated these slides to put the new prevalence rates in there, but I will. But worldwide, we know about 100 children per 10,000 may suffer from an autism spectrum disorder. We don't have this as well until now because we had DSM-4, so we had ASD, PDD, NOS, Asperger's, and then there's a ton of kiddos who don't come in or who get misdiagnosed with like ADHD or something else. Age of onset is early for autism. So 1 out of 36 kiddos now presents with an autism spectrum diagnosis. The age of onset, like I said, is pretty early, though most caregivers tend not to notice or see anything until that language or that motor development is delayed. So it's not until anywhere from 12 to 18 months that they're like, ooh, I think something is going on. And then they bring their kiddo in because from 0 to 6 months, you're just happy that baby's like, sleeping. Anywho, those are the things that you're looking for. And so since we don't see them until they're about 12, 18 months, we don't necessarily often get kiddos being brought in unless there's like, my kid doesn't look at me. So when we see our young babies being brought in, infants being brought in for possible developmental delay, where we give that kind of global developmental delay, a lot of that is they don't look at me. There might be feeding issues. They may not track things when it comes to their attention. There is significant sensory issues. Baby cries hysterically unless there's only this one sound or, things like that. Earliest point in development for reliable detection is that 12 to 18 month period. Diagnoses made around 2 to 3 years are gold, kind of most stable because they've had time. They've had time to be social with other kiddos at the park or in daycare. So we can see that social issue coming up. Communication is a bit more developed, or if not, that delay is there. Motor skills should be more developed. If not, we know that's there. And we also start to see the self-stimulatory issues around 12 to 18 months, more pronounced at 3 years and 4 years. So genetic influences, we've talked a little bit about this. We've got Fragile X anomaly occurs in 2 to 3% of children with ASD. ASD individuals have a 5% elevated risk for chromosomal anomalies, so 22q11, 21q13, 13q11, etc. And about 25% of children with tuberous sclerosis have ASD. I'm going to touch a little bit on treatment strategies for ASD because I want you to see a little bit of the corollaries of how we treat individuals with psychosis spectrum disorders. So first, we're talking about decreasing disruptive behaviors if they're present. teaching appropriate social behaviors. So I want you to think about our CBSST, our cognitive behavioral social skills training. A lot of those principles come from our autism work. A lot of the social skills trainings that we've developed or adapted rather for psychosis come from the autism world. We try to increase functionality and spontaneous communication. We promote cognitive skills and also do cognitive not remediation per se, but a lot of cog rehab, how to compensate for any cognitive deficits we see. And we teach adaptive skills to increase responsibility and independence. And again, I want you to think about a lot of the stuff we're doing with our clients, some of those rehab skills that we're focusing on to get them independent. A lot of that is coming from this world. So we talked about autism. Now we're going to talk about ADHD. The comorbidity of ADHD and psychosis spectrum disorders is a little murky. However, we do see a good 43% of our individuals who present with psychosis spectrum disorders having had an ADHD diagnosis in their history somewhere, if they're not presenting with it comorbidly right now in this moment. So ADHD is marked by excessive levels of activity, fidgeting, squirming, running around when inappropriate, incessant talking, distractibility and difficulty concentrating, making careless mistakes, difficulty following instructions, forgetful, and may have some difficulty with peer interactions. Here we see the communication issues can be from that kind of impulsivity difficulty. So cutting people off, jumping from topic to topic because their brain has already moved on and they don't realize other people haven't caught up, things of that nature. And so if you think about this, you can see how this could look a little bit on the ASD spectrum with that communication issue, with some of these activation issues, as well as some difficulty with instructions and forgetfulness. So this is the DSM criteria. I'm not going to go super into it, but we have our three types: predominantly inattentive, predominantly hyperactive, and then our combined types. And so when we're thinking about that, we're looking for 6 or more of these inattention issues or hyperactivity issues in the last 6 months prior to age 12. And for individuals who are adults, we only need 5 signs of inattention or hyperactivity in general. And I want to highlight this. It has got to be present in 2 or more settings. This can't be he's hyperactive at school. It cannot be that. Because if he's calm at home, that's school. That's not an ADHD thing. That's a school issue. What's wrong with that environment? Or he's, bouncing off the walls at home. He's an angel in school. All right. Those are environmental issues. Let's figure that out. So if someone's not in school, it's got to be occupational. There's got to be 2 or more contextual settings in which these symptoms are displayed. As I said, we've got our 3 specifiers, which symptoms predominate, or if it's combined type. Combined type is the majority of diagnoses. As of the last data I had on this was 2018, I want to say. And differential diagnosis, there's often a differential between, is this ADHD, is this conduct disorder, intermittent explosive disorder? ADHD, we see more off-task behavior, cognitive and achievement deficits. Conduct disorder is about aggression, is about antisocial engagement. So this is prevalence rates from 2015 that I found, and there's 8 to 11% worldwide. Public policy can affect diagnoses. Although we have seen it be more commonly diagnosed in young men, that does not mean it actually is more common in young men. It's more commonly diagnosed, particularly because it's ignored in young women. The hyperactivity is seen as antisocial in women because of our social mores as a nation, as a culture. Symptoms tend to persist beyond childhood. Most individuals show anywhere from 60 to 80% persistent symptoms, even into late adulthood. These are some of the treatments for it. It's primarily medication driven. I did not talk about medications in autism because that is not my jam. We learned a bit about it this morning, Sabrina and I, but that is not my specialty. And I really, really hate when they treat autism with medications. So I don't even talk about it. But that's a personal preference. For ADHD, we see stimulant medications are the gold standard. They reduce disruptive behavior, help with focus and attention. We don't know exactly what circuitry they work on in the brain besides, thinking, the dopamine and serotonin systems. However, we do see that even for kiddos, or not kiddos, these are adults by this time, but for adults who have ADHD, they'll tell you if they've ever tried a stimulant, an illicit substance stimulant, such as cocaine or something, they're like, I don't get high, but I get focused, because it's very similar for them. That response is the same as to their stimulant medications, because that circuitry in their brain has that disruption in that focus and attention. And so any stimulant is actually going to coalesce that for them. The best gold standard is medication plus behavioral treatment. It says here slightly better than meds alone. That ain't true. Newer studies, 2020 and 2021, have shown significant improvement in behavioral methods for ADHD, and even longitudinal studies have found that the superiority of meds to start with in those first 0 to 6 months of treatment diminishes after 3 years. So psychological treatment often includes twofold: parent training and kiddo behavior monitoring and reinforcement of appropriate behavior. So lots of reward systems. Think of parent management training, but also it's learning behavioral methods to enable them to focus, even if they're on meds, even when a lot of our kiddos will take medication vacations for ADHD. So no school in summer, no Ritalin. And that's to give their body and their brains a break from constant medication. And during those times, a lot of those behavioral methods will be kind of stepped up. How do I help you keep your focus and attention, keep your hyperactivity down, even when you're not taking your medications? So a lot of that is behavioral methods. You'll see stimming. So I know fidget spinners are like this new thing, and oh my God, we have fidget spinners, but they have been a thing for as long as I have been working with kids, giving them a sensorial stimuli to play with or to just fidget with. For me, because I'm a knitter, I used to just have tons of yarn in my office and be like, here, take some yarn and just do something with it. And that sensory focus enables them to actually be able to get out the jitters and the hyperactivity, and then be able to also have a little bit of focus on this thing they're doing while being able to put their main focus on class or something they're watching. A supportive classroom structure, brief assignments, lots of breaks, task focused, and rewards. So I'll often work with my kiddos and say switch on and off. If you're going to do 20 or 30 minutes of math, you get a 5 to 10 minute break to do something that is fun or engaging, but also kind of staying in the same lane. So it's not like they get to go outside and like while out. It's like, okay, if you're taking this 5 to 10 minute break, you get to do a math game on your phone or something like that. And now we move on to our early onset psychosis. So it's called childhood onset schizophrenia for most folks who in this space, but I tend to use the term early onset psychosis instead because we're talking about the spectrum. Psychosis in general is seen as a neurodevelopmental disorder because of that spectrum, as well as that longevity of those symptoms, those cognitive symptoms and negative symptoms we see well before a positive symptom even pops its head over. We know our age of onset is 15 to 25 in general, but early onset psychosis can be seen in individuals as young as 10 years old. It can be seen in 8, but that is so hard because of that theory of mind, those developmental considerations, etc. Prevalence of early onset is quite rare. Estimated prevalence is less than 1 per 10,000 children, and an earlier age of onset in boys by 2 or 4 years. Gender differences are less of an issue once they get older. So I have the diagnostic criteria for schizophrenia here. I know we don't have to go too much into that since this is our jam and we all do this, but I want to put it up here because I really want you to think about 3 and 4. 5 too, but 3 and 4, and how much that can overlap with what we see in autism, especially if we're talking about early onset psychosis in our kiddos. So, disorganized speech, frequent derailment or incoherence, think about ADHD and autism. That looks the same, especially if you're not talking about full threshold psychotic disorganized behavior that's tangential or circumstantial and has neologisms. That slightly disorganized speech, that almost sub-threshold one that we often see if they're coming to outpatient, that's really hard to tease apart if you also have some autism symptoms going on. Social occupational dysfunction, and then the duration more than 6 months, we know. We talk about schizoaffective, substance-induced, relationship to autism spectrum or communication disorder. So I wanted to have this up here because this comorbidity is super hard, and we don't really have a ton of research on it because there's not a ton of researchers who want to look at the comorbidity of autism and psychosis. Usually you're in one camp or the other, and y'all don't talk to each other all that much. However, we do know if there's a history of ASD or a communication disorder in childhood, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are present for at least a month or less if successfully treated. So you cannot use 3, 4, and 5 if there is a history of ASD. There must be 1 and 2 present as well. And the reason for that is because, as I said, these can look a whole lot like autism. And so if they're there without the presence of these positive symptoms, delusions and hallucinations, you're double dipping. Because if it's in the autism camp and you're trying to say it's in the psychosis camp, without these two, you're pretty much just giving 2 diagnoses for the same behavior. So with psychosis, we know there's often this kind of gradual onset. It's very rare that we see someone who was like chilling, fine, everything cool, Monday, Tuesday, full psychotic episode. Usually, even if it's a few days, we'll be doing kind of the forensic eval with family, and they're like, "You're right. Tuesday, he was a little off. He started acting weird. Sleep wasn't good." But usually we see a much longer gradual onset from anywhere from weeks to months up to years. Most individuals with psychosis spectrum disorders have some sort of history of behavioral, social, and psychiatric disturbances before the onset of psychosis. Developmental precursors are important to consider and examine in their diagnostic history. So as I said, Elaine Walker at Emory has pioneered a ton of good work on some of what we call these early soft signs of psychosis. Motor disturbances, gait imbalance. When we see the self-stimming behaviors, so flapping, rocking, those things tend not to be like associated with psychosis spectrum disorders. And so when we see those in the presence of these other issues, that's when you're like, yeah, that's autism. If there's not that self-stimming behavior though, and it's more like kind of just like these small tics or these like repetitive gestures, that's harder to put in one camp versus the other, especially if they go on to develop psychosis later. So with atypical gait and things like that, again, that's hard because individuals who have autism spectrum disorder will have atypical gait. They may not, like, again, it's not pathognomonic to it. But as I was saying, with those motor developmental issues, you might see their running be off. Like it looks like their gait is imbalanced. They have an inefficient and ungainly lope to their running or something of that nature. So again, that's why it's really hard to say, ooh, if I saw that, I would know that's autism versus psychosis. Other symptoms, about 70% of individuals with psychosis spectrum disorders, particularly early onset psychosis, will meet criteria for a comorbid psychiatric disorder. Often it's a mood disorder, or it could be a behavioral disorder. We do see a lot of comorbidities with OCD at this age. So 11, 12, we're seeing that OCD creep up. And man, I got to tell you, that presentation plus an possible autism spectrum is the hardest to tease apart. But as many of you who've been in assessment soup with me on this call know, it's like my favorite thing to do. So I'm a big fan of having to do that. But it's very hard. So other symptoms may not show a linkage between the COS and the ASD, like the timeline might be super off, or there's like, no, they have autism and then these other symptoms that have nothing to do with autism presented. So sometimes we get to see that like, no, this is clearly psychosis and autism because the psychosis symptoms are so concentrated and like kind of in their bubble over here, that's a clear addition. But oftentimes that's not the case we see. So treatment for early onset psychosis, CSC, is best indicated, we know. APs are not indicated for subthreshold. So I know we've talked about this. Antipsychotics are not indicated for individuals who are in that attenuated range. And when we see comorbid autism and psychosis, we often see it in that subthreshold range. And part of that is because we're having trouble with that 5 or 6 differential because of that theory of mind issue or that cognitive, impairment, and we're not sure. Or they're able to say, yeah, I know it's not completely real. And so that reality testing is there. But you will often see kiddos who have autism spectrum diagnoses in their history have had antipsychotic trials. And that is because antipsychotics and mood stabilizers are the standard treatment for behavioral and irritability symptoms in individuals with autism. So it's not uncommon to see risperidone or Abilify. Just because it's there, that doesn't mean it was treating psychosis symptoms. It was, especially if they had ASD or any behavioral issues as a kid, it was likely being prescribed for that. It's just something to think about. Medications help control positive symptoms of psychosis, as we know, can be serious side effects. They don't touch negative symptoms or cognitive symptoms. That's where we come in. And they often have to change throughout the lifespan, as someone grows, especially our kiddos. What they need at 11 is not what they need at 14 or 15. It's not what they need at 18, 25, 35, etc. I wanted to have this here so we can talk about the differential diagnosis. So let's look at just the cognitive symptoms here. Some significant pragmatic language and learning. We see that less in psychosis, not none, but less. Theory of mind is significantly diminished in autism spectrum. So that thinking about your own thinking about the thinking of others. Do you hear something that other people don't hear? That requires so much theory of mind in that one question. Do you know that you're hearing something? Other people can't hear it. It's not something you should be hearing. It's not coming from external stimuli. Do you see what I mean? Like there's so much that goes into that one simple question. Someone's got to have the cognitive ability to understand it. That's significantly diminished in our ASD kiddos. We also see executive functioning issues, so that planning, problem solving, and our social cog impairments. The biggest cognitive issues in psychosis are executive functioning, social cognition, and working memory and processing speed. So if you're just looking cognitively, yeah, man, you see that overlap and makes it a little harder to tease apart. But again, the quality and the context is different. These are long-standing impairments. With psychosis, this is a hit usually that comes a little bit before and is persistent even after the diagnosis. So when we say this is due to psychosis, we're talking about it's linked to the timeline of psychosis symptoms. Sensory symptoms we see, so sensitivity to sound, to light, to certain textures and other sensory inputs, texture or sensory stimming, stimming movements. Here we'll see hallucinations, perceptual abnormalities, as well as sensory symptoms, again, or sensory sensitivities. Again, with autism, this is longstanding. That sound sensitivity, light sensitivity, these things are there from ages 1, 2, 3, 4. They're not new. Whereas here, this should be new. This shouldn't be, oh yeah, this has been all my life. Like parents even know, oh yeah, he's always been really sensitive to light. Then that's not a psychosis symptom. That's an autism symptom. Thought symptoms, so rigidity and insistence on sameness, don't see as much. Stereotyped interest, echolalia. One thing I did not include in the thought symptoms are an over involvement in fantasy play. And we see this early on, 5, 6, 7, but all the way up and through high school. And that's where it gets really difficult when we're trying to say, is this a delusion or an unusual thought, even a hallucination? So one of the examples I want to give is a young kiddo, and she heard the voices of anime characters. She would interact with them. There was an entire world that she had developed with these anime characters, and it was really distracting. She would be in school talking to them, playing with them. She would want to go and jump around and do some other things. They would get in fights with each other, and so she'd be like, "Calm down, guys." It was very, very distracting. And so she gets referred, and the way she's talking about them, it sounds like hallucinations. The way she's discussing them, you would think that they were outside of her control. But it took, I want to say, about 3 separate assessments before I was able to really, really ask the question in the the right way for her to say, "Oh, I know they're not real. They were part of this anime show I used to watch a while ago, and like now they're my friends." And even in that sentence, "and now they're my friends," I was like, "Wait, so do you actually see them and hear them?" And she's like, "Yeah." And I'm like, she's like, "But they're not real. They're in my head." And I'm like, "Oh, so this is yours." She's like, "Oh yeah, I just have a great imagination." But it took so long to get there because the questions and the way I was asking them, she was answering me very concretely. And this fantasy world that she had was so elaborate, and it had infiltrated everything, and she could see, like, but she was like, "Oh yeah, I can picture them. It's super easy." And the way she talked about it, she was like, "No, they're not in my control," because she thinks of them as characters who are autonomous, even though they're part of her head. So do you see how even just this one example, it was so, so difficult, especially because it was disruptive. She could not sit in a classroom and be okay with paying attention because she was so involved in this fantasy world that she had created. So when we talk about like disentangling delusions for individuals who have autism spectrum disorders, this is one of the issues that can be particularly difficult because that theory of mind and the way you ask the question has got to be appropriate for their level of cognition and their level of theory of mind. Negative symptoms, very similar, super difficult. So really it's your positive symptoms that kind of make or break these diagnoses. So there are times when the fantasy world starts to actually become out of their control. And it becomes distressing. It can become like, I know I don't want them to do that, and they're doing it anyway, and it becomes to a point where, ooh, this is jumping into the delusion camp. So really, when we think about what a delusion is, it is a fixed and firm belief that does not respond to any reality testing. They aren't able to do that. They're not able to entertain the possibility that there is another alternative explanation and things like that. That's a fixed delusion. However, even if they're reality testing, but it's distressing, that's where this gets really murky. So calling it a delusion, maybe not necessarily. However, once it gets to a level that is distressing, it's completely out of their control, and they're like, "I don't like this anymore, and I don't want to think about it," and it's happening, that's where we know it's crossed over. So it's not uncommon for it to start sometimes as fantasy, this really elaborate fantasy world that they've built, and it's morphed into something that now is super distressing and they don't feel they're in control of. And that's where we really see that shift from this is autism over interest in fantasy to that's a delusion and that's psychotic. Similarly for P4 symptoms, oh yeah, I see and hear, imaginary friends. Are they your friends? Yeah. Do they cause you any distress or impairment? No. All right, cool. Well then, good job you. Even when we see it at an older age, because an imaginary friend at 14 is a little suspect, right? You're like, ooh, hold on, at 14, you should be done away with that. However, autism, often cognitive age, but even emotional age is diminished. And particularly that loneliness that comes from seeing your developmental peers leap ahead of you more and more and more and more as they age. You can see some of those, like, I have imaginary friends, things like that. when we're talking about ADHD, again, you'll see ADHD oftentimes in in the history of someone who has psychosis. The differential here, not as big of a deal, though it can come up, particularly if you have ADHD with comorbid trauma. The tangentiality or circumstantiality of speech, especially when you're talking about something distressing and traumatic, can very much look like disorganized communication. Disordered thoughts and loosening of associations or daydreaming can very quickly look like delusions, or at least, subthreshold unusual thoughts in someone who has ADHD, particularly when we're talking about trauma or something of the like. Um, Negative symptoms, so there can be some avolition, forgetfulness, mental fatigue, and things like that. We usually don't need to make this differential. We often need to say, is it both? And so I'm big on not double dipping. If you're going to put it in one camp, I'm not a huge fan of you putting it in another. So if you're saying they're having trouble with paying attention, so inattentiveness is also a mood disorder symptom for depression and things like that. Put it in one camp. That's the camp it belongs in, unless inattention is exacerbated during a mood or psychotic episode. That's different. So with both of these disorders and with all of our neurodevelopmental considerations, when it comes to the diagnosis of psychosis, the main takeaways we're trying to think about are which camp, is it this camp or that, and the length of time the symptom has been present. How long has this issue been there? If it's been there for quite some time, we're talking year one through life, it's less likely to be a psychosis symptom unless we've got that P4, that P1, P2 that's present as well.